Hi everyone, I'm Dr. Andrew O'Leary. I'm going to talk to you about what you might want to do when you get asked to see a patient with a high respiratory rate, with a focus on what you do if you're on call. So we'll talk about how you might want to approach all of this. So first of all, thinking about the handover. So you've just been called up and you've been told by the ward nurse that this patient's got a high respiratory rate. You're going to want to have a think and ask some questions so that you can prioritize and think about where this patient may fall on your list if you've got several others that might need seeing. And again, there'll be another video on prioritization separately, but one of the main things you'll need is a set of observations. So just how high is the respiratory rate? Are they hypoxic as well? Do you need to ask them to put some oxygen on before you get there? These are all things that you might want to think about, and you want a brief history as well, so you might be able to infer what the problem might be before you get more information, and that can help tell you how serious the situation might be. And it will tell you, is it an emergency? Do I need to get there right now, or can I get there in 20 minutes because I've got some very important things that I'm in the middle of? And yeah, so what did they come in with? What is the context? Get a bit of that information, and what are we treating them for, and what are we using? So that allows you to prioritize and do things in the most appropriate order and manner. So when you get there, if you're not sure what's going on, if you don't know how unwell they are, or you are concerned, then do an A2E. That's your bread and butter, isn't it? But if they are stable and they're not very unwell, and you've been able to finish some other bits first before you get there, reading the notes is a very useful thing. It gives you context, and when you come to possibly discuss it with the registrar in a little bit, then that allows you to give them a fuller picture when you do talk about it with them. Patients with difficulty in breathing are often quite anxious, even if they're not prone to anxiety. So what you're going to want to do is reassure them and help them settle down, because they can get breathless to a degree and then they'll become more breathless. It's a sort of negative vicious cycle sort of thing, and they get more breathless because they're a bit breathless, and then you can help settle that down just by hopefully reassuring them. And when you do get to see them, you're going to do your history and examination, and that will start directing your line of thinking after having read the notes. If you get to the having done your history and examination and you're still not too sure what's going on, documenting and laying it all out over a side of A4 or so will help you to rationalize your thoughts and think the whole thing through and assess what you think is going on. And even if you still are clueless at that point, but you are a bit worried, you can call the registrar and give them a nice overview, because that's what you've just written out. I think that's a really useful way of doing things. It makes it easier for them taking the handover, and it makes it easier for you giving it. You've basically written it out already. So, if they are unstable, if they have low saturations or their respiratory rate is very high, you're going to want to go to them straight away. You might want to get help straight away. You might want to pull the call bell. If you, again, I've said before, if the thought crosses your mind, do I need to put out a peri-rest? I'm really, really worried here. The answer is you do need to put one out. You might not have that much clinical experience at this point, but if you're worried, then there probably is good cause to be worried, and no one's going to be upset for you being a little bit over cautious rather than under cautious. So you'll be asking extra pairs of hands at all the help that will come to you on the ward. You will be the team leader initially in this instance until the registrar comes along. You will need someone to bring a crash trolley just in case. Hopefully they're not crashing already. But if you call the peri-arrest team, they're going to want a crash trolley. And if they're very hypoxic, then you're going to need a non-rebreathe mask or whatever else is appropriate in that particular context. What I would advise is always staying with the patient. So you've reassured them, they're not going to be very reassured if you walk off. And in theory, there's plenty of nursing associates and nurses on the ward that can pop off and do the extra bits. And you definitely want at least a couple of people there with you to help, and if the worst did happen, then you need a couple of other people there with you to lie the bed flat, and if is appropriate, start resuscitating. So when you're going through everything and history and examination and reading the notes, you're thinking in a systematic way. Hopefully you're thinking, well, what are the causes? What could the cause be if it's in the lungs? Is it likely to be in the lungs? Have I heard some crackles? Could it be an infection? Could it be fluid overload? Is there a chance, if they're not anticoagulated and they've got cancer, but there was a reason we couldn't give them heparin, or it was missed? Could they have a PE? All these things are going to go through your mind. And have they had a procedure in their chest wall that could have caused them to have a pneumothorax? Or is it more likely that they have ACS? Did they come in with an MI and they could have a complication of ACS, like a valvular rupture or another episode of MI? Have they just had surgery and had a lot of blood loss? Could they be anemic? And this is where the onset. So you can, in a lot of cases, I mentioned Socrates, as you all know very well before. That's usually a good way of getting a nice comprehensive history, because onset in there is also very important. So sudden onset, you are worried about an event like a PE or ACS or something like that. If it's kind of come on through the day, then it could be something brewing like an infection, or a slow bleed like causing anemia. So you could also have systemic problems. So they could be becoming septic. Look at the rest of their OBS, look at the patient themselves. Have they just been given a dose of penicillin and they're pen allergic? Fill out an incident form and diagnose anaphylaxis, and definitely call the rest of the team. Have they just had surgery, and could have they just had bowel resected? This is one thing that happened to me one night. Bowel resected and then came apart, and it's incredible how quickly people can go off, and we won't get into that. So there are other cases, as I've said, post-op and immune suppressed as well. So there are lots of things to consider there, but there are obvious causes and non-obvious causes of a high respiratory rate. So when you're doing your investigations, you're going to be thinking about, what have I found to this point? If you found that they were hypoxic, then you're going to be doing an ABG. If you found that they were tachy, you're going to be doing an ECG or asking for one. You're going to come to looking to do bloods, and you're going to want to direct them rather than just doing every blood test you can find on the system, and do it intelligently. And then you're going to think, well, do I think it's a simple infection? I'm not very worried, but I'm not, like, maybe if I start them on antibiotics tonight, they will have had 2 doses by the morning ward round, rather than 0 doses if I don't do anything. And that's almost a day's worth of antibiotics that could start getting them on the mend. So thinking about that, if you're out of hours and you're worried about a PE, they might not be doing a CTPA depending on your hospital, but it might be that, again, discuss that with your registrar, but it might be that you end up starting them on treatment dose Clexane or whichever heparin or DOAC you might use in your trust for that. And the final thing is you've got to escalate it as appropriate, and I've touched on that throughout. If you're worried at any point, especially earlier on in the year, if your first few sets of on-calls, it's expected that you'll feel a bit out of your depth in situations where actually later on, with a bit of experience in the year, you'll feel a bit more comfortable. And you need to be you need to start a bit overly cautious before you can start developing your clinical acumen and start building up that confidence and not having to call quite so frequently. Any bloods that you've taken that haven't come back yet, if you are worried about infection but you haven't started antibiotics because you're not too sure, then hand them over and make sure that they get chased up. And of course, any imaging as well. If imaging is going to happen out of hours, it should be looked at. And and if you started, say if they were short of breath because they were overloaded, and a bit of frusemide helps. Well, if you then go and then they have no more treatment, especially if it's over the weekend, for example, for a couple of days, well, it's just going to happen again, or you're going to see them for the same thing tomorrow. So you might need to initiate something regular. And always, when someone's quite unwell, check their escalation status, and if they are potentially fit for escalation, if they do become more unwell, and talk to ITU and let them know that there's someone who's a bit unwell, and maybe when you get a chance, come and see them and see what you think. Or I say a bit unwell, that'd be if they're quite unwell. Don't bother them about everyone who's got news of 3. They won't thank you. But that's everything we've got for now, and I'll see you in the next one.